now. We'll start with Dr. Buck. Dr. Buck is an associate professor of pediatrics at the UCLA David Geffen School of Medicine and director of the UCLA Mozambique Partnership. Dr. Buck did his undergraduate work at Wake Forest University, medical school at the University of North Carolina, Chapel Hill, his pediatric residency at the University of California, San Francisco, and has a master's in public health from the London School of Hygiene and Tropical Medicine. After residency, he joined the Baylor International Pediatric AIDS Initiative in Malawi, where he worked from 2007 to 2013. He worked with CDC Mozambique from 2013 to 15 as the National Pediatric Advisor and has been a country focal point for the UCLA Mozambique Partnership since 2015. He's also a technical advisor for the Mozambique Ministry of Health in the areas of pediatric HIV, pediatric TB, and drug-resistant TB. Welcome, Dr. Buck. And now I'll introduce Mercia Matsinhe. She's the pediatric advisor at USAID Mozambique. She got her medical degree from the Universidade Eduardo Mondlane and did her pediatric residency training at Hospital Central de Maputo. After residency, Dr. Matsinhe joined the Instituto Nacional de Saúde, where she worked as project coordinator for 2 pediatric TB studies, TB Speed and RAPID from 2019 to 2021. She has been with USAID since 2021 in this role, works as a technical advisor to the Mozambique Ministry of Health in the areas of pediatric HIV and pediatric TB. Bem-vindo.
Thank you so much, everyone.
Impressive portrait. Well done.
Yeah.
So guys, it's really always great for me to get to interact with the students in the pathway. We have students here with us, second-year students, Joseph and Shannon. And I just want to say, for me, really, before we even start, it's really cool to have Mercia here participating with us today. I met Mercia, she was a resident here when I started working for UCLA, and I've followed her career development as she finished her residency and went on to do some research work, and now have like a senior leadership position at USAID. And so, you know, I think these discussions that we have, when we can include local voices, and particularly in this discussion, we're going to be talking a lot about young women, and having a Mozambican woman who's a physician leader with us is great. So thank you, Mercia. So what are we going to do today? We have an hour, right, guys?
Yep.
Yes. So we're going to talk about what are some of the social determinants of health when we look at the transmission of HIV from mothers to babies here in Mozambique. Can you guys see my screen okay?
Yes.
I'm gonna do a slideshow and see if this works better. Still good?
Yep. Perfect.
Cool. So our learning objectives, want to kind of just quickly teach you guys about what are some of the key strategies and interventions that we try to do for prevention of mother-to-child transmission of HIV. We want to look at how Mozambique is doing towards its goal of eliminating mother-to-child transmission. And then we want to talk, most importantly, about some of the country-specific social factors that affect key aspects of care and prevention. So I want to start with some data that will help contextualize our discussion. And this is a pie chart that we're not happy about. This is a data from 2020, but it shows the international estimates about where new pediatric infections are coming from. And you can see Mozambique is the second largest individual piece of the pie. Nigeria is the number 1, and they have a population that's 8 times as much as Mozambique. But for countries of our size, we're definitely one of the countries that's lagging most behind in terms of making a dent in prevention of vertical transmission. And so unfortunately, this is the context in which Mercia and I are currently working. This is a graph that's a little bit hard to see on your screen, but essentially these are for different countries. What is the estimated vertical transmission rate? What percentage of HIV positive women transmit the virus to their babies during pregnancy or during breastfeeding? And the last time they did a good national estimate, we were at 14%. In these bars, the green is transmission during pregnancy, and the orange is transmission during breastfeeding. So you can see for us, a large portion, we think more than 50% of our new pediatric infections happen during breastfeeding. And unfortunately, as you can see, we have not been able to have put a really significant dent in our new pediatric infections per year. So there's a lot of partners, not just the Ministry of Health, but various ministries in the Mozambican government, various implementing and clinical partners and other international organizations that are all working to try to improve on this. And at an international level, we often talk about these different pillars of work or pillars that we can use to focus on trying to prevent children from being born with HIV. And so over the course of our hour today, we're going to kind of visit each of these pillars. I'm going to speak a little bit about each one from like a clinical perspective, and then Mercia is going to lead you guys through a discussion about what some of the social determinants of health factors that might be contributing to our challenges are for each pillar. So we'll start with this first one, which is, if you want to prevent babies from being born with HIV, the very first thing you should do is try to prevent young women from acquiring HIV infection. And so what we know is that young women have biologic and social risk factors to be infected with HIV. And this graph here shows at a national level, much higher prevalence rates in young women compared to young men. These graphs here show that there's not very good consistent use of condoms in sexually active young adults. And this shows that we have even worse rates of performance when young people who were surveyed were evaluated about their knowledge of HIV prevention. And so similarly to that pediatric graph, you can see we have not made much progress in terms of reducing new infections in young women over the last decade. Another big challenge that we face here is seroconversions after being engaged in care. So this refers to women who show up for their early antenatal care and their first test is negative, but then become newly infected during their pregnancy or during their breastfeeding period. When this happens, there's a very high risk of transmission of the virus to the baby, and in this situation, the moms usually don't even know that they're HIV positive. So this is something else that we're struggling with here. So with that quick intro, I want to turn it over to Mercia and ask, what social factors might explain the higher risk for HIV transmission that we see in young women.
Thank you, Chris. I would like to hear from you first. What social factors might explain higher risk for HIV transmission in young women, in your opinion?
Yeah, so this will be great if it's participatory. Maybe one or two students who are on the call might want to offer up an answer. I can't really see the screen, so Raven, if you could help maybe take volunteers, that would be helpful.
Sounds good.
We don't want to have to call names.
Yes. Start to call volunteers.
Yeah, don't be shy, guys, about just taking some guesses on what these might be. Oh, there's one in the chat there.
Yeah, so Camille says maybe gender norms.
Yeah.
Thanks, Camille. We got Joseph and Shannon here. I can put you guys on the spot. Any thoughts about social factors that could explain why young women are more likely to get HIV as opposed to young men?
Patriarchal stigma and access to medication. Clinics are located in certain places.
Did you guys hear his response?
Not that well, if you could repeat it, I think, Chris.
Here, I'll move a little bit forward. There's a lot of like patriarchal stigma over getting treatment for HIV and obtaining ART at clinics and stuff like that.
Also, I'll add some more and say that every hour 4 adolescent girls and young women are infected by HIV here in Mozambique. And some of the factors are related to poverty, and poverty makes girls vulnerable to premature marriage. And sometimes they marry to older men who are already infected and not. Or poverty makes girls vulnerable to intergenerational relationship, not just premature marriage, but intergenerational relationship and multiple relationships. And also poverty makes girls to be dependent to their partners to decide if they will use or not prevention methods like condoms and PrEP. And we have cultural norms here that contribute to this high HIV infection, and low educational levels and poor health literacy. I think that these are one of the social factors that may affect girls to be more infected than young men.
Thanks, Mercia. Yeah, and so, it's interesting for those of us who are trained as doctors, often when we think about prevention, we're not thinking about this pillar, but there's folks who are, educators and policymakers who are really trying to focus on this first pillar and figure out what they can do to help improve young women's literacy and their education and their access so that they can make the decisions and be in a place to make the decisions that can keep them HIV negative. So Mercia probably does more work in this area than me,
Yes.
But in me in the hospital, this is something that I really don't have much impact over, but it's an important part of the cascade. The next step that we might go to, frozen here, let me see if I can advance, is the second pillar. Whereas let's say you have a young woman who is HIV positive, we want to make sure that she's only having pregnancies when she wants to, and that she has access to family planning services. So here's some national data about how we can try to prevent, how we're trying to prevent unwanted pregnancies. So the chart on the left shows of all the health facilities in the country, what percentage of them offer the different contraceptive methods listed there. Not all of those are great for HIV prevention, but all are effective contraceptive methods. And you can see that overall, the light blue bar, we're doing a pretty good job. 94% of facilities offer at least one method. But you can see the same graph on the right looks at the number of facilities that offer adolescent and youth-friendly services, a provision of these same services. And we don't have as good a coverage. We don't have as many providers that are well-trained to kind of particularly take care of this age group. And so that's a challenge that we have. So go back to Mercia and back to the students, hopefully volunteers, but what social factors might explain the low uptake of family planning services in Mozambique?
I will start and then I will allow others to add. We have low uptake of family. One cause of low uptake of family planning services can be the family pressure to have children. And again, poverty. Some adolescent girls and young women are married to older men, and they are not empowered to make their decisions alone. They have to hear from mother-in-laws sometimes, or their husbands, and they don't decide. Even when they have access to family planning methods, they need others to decide which one will be the best, and they have this pressure to have children, to have more and more children, and sometimes they die trying to satisfy this cultural norm. The second cause I will say is that sometimes girls live very far from health facilities, and we saw in the previous slide that some health facilities provide family planning, but not appropriate for the specific target. So some ladies or some adolescent girls and young women have their activities and they don't have access to the health facility because of those activities. They go to
the fields.
Yes, to the fields in specific times of the year. So they don't have access. And we have lack of empowerment to make individual decisions for healthcare, not only for family planning, but for the whole cascade of health. And poor health literacy and knowledge of options. We have the methods there, but sometimes the providers are not able to explain clearly which one is the best. And sometimes the providers don't give options. They choose the method that they think that it's easy for them to apply to the women that attend to the health facilities. So we have all of these problems related to the access to family planning. But when we go to the health facilities, we have access, we see those methods available there at the health facilities, but we know that we still have a lot to do to make sure that we understand which method is the best for their situation. And we also need to empower the women to make individual decisions about their own health, to decide when to have children and when to stop to have children, because sometimes we have young women being suffering for this social pressure to have more and more children and being at risk of death and other complications related to obstetric situations. Thank you.
Thanks, Mercy. And I'm curious, it's always impressed me here in Mozambique, this really strong family pressure for young women to have children, and start at a young age. And I see this across kind of socioeconomic classes.
Yes.
You're a mom of three. But
yes, I'm a mom of three.
When did your family start? When did you start feeling that pressure from your own family and your in-laws? And
okay, in my case, I didn't have this pressure. In my family, we have a different history. A lot of women in my family have only one or two. I'm an outlier in my family. But we start to see this when we are 25. Yeah, we have a lot of pressure to have children. If you have girls like me, I had two girls, so you suffer boys, or if you have only boys, you have a pressure to have girls. To continue the family name, we have this. This is our cultural norm to continue the family name. You have to give a boy to this family. So the pressure, it's not an exclusive situation for poor women. It's for all social structure, all women, women with PhD, without any educational level, we have this cultural pressure to have children. Yes.
Very interesting. Thanks. You know, and one thing that we're trying to do in the National HIV program is make sure that family planning services are integrated into HIV care, so that young women who are in HIV care, if they want to have family planning, that they don't need to go to a different clinic and see a different provider,
Yes.
but it can be like a one-stop visit so that they can get these services at the same time. And how is that going?
We are discussing this in the Minister of Health level to include family planning service into the differentiated model of service. But now we are delivering in multi-month drug dispensation. The patient goes to different doors in different days, but they have access to multiple dispensation of oral contraceptive, or they use injectable, and we do not make limits looking to the ARV regimen and say that this method doesn't combine with this one. We deliver, or we allow the patient to choose which one the patient wants, and we are trying to make to reduce the visits to the health facility. So it's possible to make injectables methods, and oral methods are available for 3 months.
Great.
Yes.
Thanks, Mercia. Any comments or contributions from the UCLA side? I see a comment from Sana here. Dr. Matsinhe, you mentioned that sometimes the physicians may decide for the patient instead of consulting them. In your experience, does this lead to lower trust in the healthcare system?
No. Yeah, here we have a different situation because our patient trusts us. So it doesn't reduce the trust in healthcare system. I think that sometimes because of this lack of education of poor health patient trust in providers, but what we need to work now is to teach the providers to respect the patient opinion and to explain what they have available and allow the patient to choose the best, not the provider to choose for them. But it doesn't interfere in trust because we have this health literacy that is very low. Yeah.
Well, thanks. Great question, Sana. I think we'll move on. And we're going to turn to pillar 3. And so when a lot of people talk about PMTCT, this is what they actually think about. And this is when we start getting into like some of the biomedical interventions, the use of drugs and other things to try to prevent vertical transmission. And so I'm going to give you guys a little bit of background about this. You know, we know that HIV can be transmitted from mom to baby during pregnancy. The childbirth is a particularly, peripartum period is a high risk time, but also through breast milk. And we know that roughly a third of infections come from each of these different time periods. If at a national level, how do we go about trying to implement a program to reduce from HIV positive women who are pregnant? The key thing that we have to start with is we have to do HIV testing in antenatal clinics. And this graph shows you for all of the 11 provinces in the country, and then for the national level, how we're doing in terms of testing coverage. And you can see the lowest one there is 97%, and the highest one is 100. This data is a little bit old, it's 3 years old, but the key message here is that all provinces are doing a really good job testing pregnant women when they come for their first antenatal consult. I'm going to skip that part. This is an interesting slide which shows a different kind of take on this. And what is recommended is that women attend their first antenatal clinic visit with the male partner. And when that happens, they can be tested for HIV together as a couple. And Mercia is going to explore all the benefits of testing as a couple as opposed to testing separately, I think, in her comments. But what you can see here, and if you look specifically at this light green bar line in the middle, this shows you the percent of women who had their male partners present at their first antenatal clinic. And you can see that there's in the northern part of the country, there's a little bit more of a matrilineal culture, and women often have their male partners present when they go for their antenatal visits. But in the southern part of the country, including the provinces where we do most of our work, it's quite uncommon to have men involved. And so you guys might think a little bit about what kind of difficulties this might create for a woman if she's newly diagnosed with HIV and her male partner isn't there and he wasn't tested. Since I started work in Malawi, even before I started working, there's just been a general trend towards using more and more drugs to prevent HIV transmission, both in the medications we give to mothers. We're used to give prophylaxis, and now we give them full antiretroviral treatment for their own health and for prevention reasons. And in babies, we've gone from giving a single dose of nevirapine around the time of birth to using longer courses of nevirapine and AZT. And I suspect someday we're going to get to using full ART for babies, but we're not there yet. But underlying this whole movement that we've experienced over the last decade and a half or 2 decades is this concept that patients who are undetectable, who have suppressed viral loads and don't have active HIV replication in their bodies, are essentially uninfectious. And so our goal when we're looking at these pregnant women who are HIV positive is to make sure we get them onto treatment so that their viral loads are undetectable and their babies are at low risk. This is a graph that shows how we're doing nationally in terms of transitioning women from prophylaxis, just using 1 or 2 drugs, which are these yellow bars, to using full ART, which are the dark green bars. And so you can see there was a really quick transition in the country at this point. This is, again, slightly old data, but we're not using prophylaxis for women. We have what was called test and treat. So as soon as a patient, and not just pregnant women anymore, but really any patient in the country, as soon as they test positive for HIV, they're eligible to start treatment. They don't have to wait to reach certain clinical or immunological thresholds. This graph, I think is the same, sorry. This is a graph that's a little bit more problematic for us into the details, but essentially what it shows is there's an entire cascade of interventions that have to happen from the time a pregnant woman with HIV enrolls in antenatal care, through her childbirth, through the breastfeeding period, until the time that her infant gets a definitive diagnosis. And we have trouble with retaining moms and babies in this cascade of service. And along the way, we have attrition and loss to follow-up, and that contributes to negative outcomes. So knowing, Mercia, that we have the medical knowledge to be able to prevent HIV transmission, treatment works. What social factors might explain why we have this poor adherence and retention in this cascade of services?
I'll start to talk about low male partner involvement and explain the difference between the North and South. We saw that North would have more participation of men. They are very involved in the antenatal clinic and they follow up all the process of pregnancy until birth. But here in this, we are in south of Mozambique, Maputo, and we saw that Maputo, Gaza, and Nyambani have a different pattern. But this happened because we are very close to South Africa and a poor country with low reduced opportunities of jobs. So men start very early to move to South Africa to find jobs in mines and fields, and they come here in some specific months, April and December, and we have this pattern in births also, and that's why we don't have this involvement of male, and we have the incidence of HIV was higher in these areas because of this movement for South Africa to Mozambique. You know that South Africa is still lagging. Yeah, they don't have the situation controlled yet. And we have those males that travel to South Africa. They don't have access there to treatment, and they come here with higher viral load than fed women, and they can marry more than one. It's possible because they have money. And we discussed it before, the question related to poverty, the intergenerational marriage, and multiple partners. So this is one of the factors. We don't have partners involved. And when we don't have partners involved, we'll struggle with disclosure. Women will not disclose their HIV status to their mothers-in-law because in those areas, they are very. When a woman gets married here in Mozambique, she belongs to the male family, and the mother-in-law will be the one that will decide about the treatment, family planning, every prophylaxis for the child. So they don't disclose. We give them the treatment, and sometimes they take IVs during pregnancy, but after birth, they don't have a follow-up because we have two different doors. After birth, one needs to go to the IV visits, CCR, and she also needs to go to the maternal and child door. And this door has a very big interval of visits. They schedule visits for 7 days after birth, 1 month after birth, and 2 months only to see the child. So this woman is alone. No one will call her to go back to the health facility to test for the child, and no one will support her at home to give IVs for the child and for herself. So we have this disclosure is a very big problem because they abandon treatment or they switch treatment from the bottles to a plastic bag, hide the medication at home. So we have this, and we will talk about the mental mothers strategy in the next slide that are helping us to overcome this problem. And they have other activities at home. And I've talked about poverty and stigma. They have self-stigma, and they are afraid to suffer stigma from their community if anyone finds out that they are HIV positive. So the disclosure is one of the big problems.
Thanks, Mercy. It's interesting. You mentioned the non-disclosure. In my work in the hospital, I would say that often when I make a new HIV diagnosis in a baby, I find out that the mother hasn't been able to disclose her status in her home where she lives, whether that's to the baby's father or to other family members. But it's really almost impossible to conceal the interventions, the medical interventions that we want to be doing, if you haven't told people what your situation is. You know, it's not normal for newborns here to be taking 2 syrups twice a day for the 3 months after they're born. And if everybody at home is going to be asking you questions and they don't know, many infants, you know, will look at and it'll say that they're receiving prophylaxis, but in the reality, as Mercy mentioned, the moms might have thrown those bottles away. The treatment that the moms do is more discreet. It's 1 pill once a day now, and it can be easily tucked away somewhere, but particularly for the infants, it's hard. But you know, it's some of our relationships here, Mercy had talked about the economic vulnerability of some of the women. But you know, you have to think about the situation in which she lives. If she doesn't feel comfortable revealing something as important as this diagnosis to her partner or family. So for me, I think this is one of the huge areas where we really need to kind of close our gaps in Mozambique and work to reduce stigma, work to make this a disease that is as normal as any other that people might have, if we're really going to drive towards elimination.
And sometimes they are afraid of the violence, the intimacy violence related to disclosure. When they reveal that they are HIV positive, they can be victims.
And we've also all had cases where a mom tested positive, revealed her status to her male partner, and he left her or abandoned her. And so fear of abandonment, fear of, you know, how's she going to live, how's she going to eat if her employed, you know, male partner leaves her. These are all really real challenges that we face here. Any questions or comments from other participants?
Thank you for sharing. So it sounds like there is a social stigma and bigger issues than outside the healthcare system. And I wonder if there are any ways to mitigate this with public health policies and campaigns, and also at the same time providing women maybe stability outside of these social structures they are in. And I just wanted to know if there's anything like this going on, or are we trying to just recruit women to come and get the medication for them and the infants while working inside?
Yeah. Go?
Yes, there are a lot of things being done to overcome this. One is in our PEPFAR, it's supporting programs to empower women, adolescent girls and young women to be educated. And so we have this DREAMS program that has this goal to empower women. It looks to education, gives financial support, and also address things related to violence, stigma, and prevention of HIV. This program is specific for adolescent girls and young women who are HIV negative. And there is another one that focuses on HIV-infected families, which is OVC, Orphan and Vulnerable Children Program, that support families and give financial support and help with disclosure. And we have the Mentor Mother Strategy, which was designed for women with HIV, mothers, to other women with HIV. So we have women with HIV in all health facilities that support those mothers. And they allow mothers to choose if they want to be supported at the health facilities or in the community. It's a peer mentor program. And we have another program for adolescent and youth. It's called youth case management. It's for adolescent and youth affected with HIV. It's a peer mentor program to support HIV. And the peer mentors are trained their peers and talk about stigma, TB, disclosure. They share their own experience and they help families to talk about this without stigma. I can say that way. Yes, and we have a very big campaign that it's called Somos Iguais. That means we are all equal. This campaign is a massive campaign. We see this in television, in outdoors, in radio, and we have someone with HIV that say that we are all equal. You only have to take your pills to feel healthy, and you can do everything. And I think that this campaign has a very huge impact for all of us affected and infected by HIV. So this is some of the activities, but they're very big activities, so that we have a very big program, and we still have a lot to do, but we are trying to move forward.
Thanks, Mercia. Mercia mentioned something called PEPFAR. You guys might not all know what that is. It stands for the President's Emergency Plan for AIDS Relief, and it's a program that was created by the United States government to really catalyze the HIV response in sub-Saharan Africa and other countries in the world that were heavily affected. So PEPFAR, there's some areas where it's largely recognized as something that's really changed the face of HIV in Southern Africa. So Mercia works for USAID. CDC is the other big US agency that implements the PEPFAR program overseas. And Mozambique on an annual basis gets like $250 million. It's $250 million or something like that we get every year. So Mercia is saying we're up to $400 million that the government of Mozambique receives from the United States government to support HIV programming here. So as American taxpayers, it's something you guys should all feel proud of. Go ahead.
And about retention, what we are doing now is to give medicine for 6 months to allow the women can do their activities and take meds. And we also have mobile brigades. The health facility moves to a remote area to deliver family planning service, TB screening, and IRBs.
Thanks. Yeah, and Sana, I think you asked a question. Mercy touched on the issue of stigma. I think one thing that we still lack at a national level, this Somos Iguais program that she mentioned is important, but we don't have a national champion, a national face of this, somebody who's a high profile public figure who's come out and revealed their sero status to others, try to help take away stigma, a Magic Johnson type person who could really, make this something that is more identifiable to the masses. So, hopefully that leader is out there, and hopefully somebody will have the courage to come forward and do that for us in the future, because I think it would have a big
Yes, we still don't have a public face.
Yeah. We're going to move on to the next part of the presentation here, and to pillar 4. So pillar 4 is a recognition that this is not, for the HIV positive woman, her pregnancy and her breastfeeding is not the end of the road for her. For those of us who work in the area, we might be thinking about the end outcome for this infant, but this is a woman who has a chronic lifelong disease, and her family and other family members are infected. And we really need to be thinking about how to use the interventions we do for prevention as the foundation for ongoing care for her and for her family, so that they stay healthy. And then, so if she chooses to become pregnant again in the future, that the likelihood that she'll transmit HIV to her baby is reduced. So it's quite interesting. And so this shows, again, it's a little bit old, but the data is still relevant. But it shows for every province in the country, the women who are HIV positive, who are getting some sort of treatment for prevention. The light green bars are women who newly were diagnosed and newly initiated ART during their pregnancy. But the dark green bars are women who were already known to be HIV positive and already on antiretroviral therapy when they became pregnant. So this is less and less becoming a disease that's newly diagnosed during pregnancy, but more and more something that pregnancy happens in women who have been diagnosed and are already on treatment. And so that's different than it was when we started our response to the epidemic a decade ago. But when we talk about chronic HIV care, just like we had trouble with the retention in the PMTCT cascade, we also have big challenges in Mozambique in retention and antiretroviral care for those people who aren't pregnant or lactating. And this graph, which is again a little bit old, but Mercia probably has more updated data. But at a national level, when they looked at this in 2019, only 67 people who initiated ART were able to be identified that they were still active and in care 12 months later. So we have a bucket with a big hole in the bottom, and we're trying to fill it up as quickly as possible, but we need to stop that leakage at the bottom. And this is interesting because our data are much worse than many of our regional neighbors. There's something unique about Mozambique and our population and the way they live that makes retention and ART care a different challenge than it is in places like Malawi and Botswana and Swaziland and South Africa. The graph on the right is a cascade that we look at a lot these days. And it was originally called a 90-90-90 cascade, and now we've changed it to 95-95-95. But this was something UNAIDS put together as to help countries set goals. And they say that they want 95% of all people living with HIV to be diagnosed, and we want 95% of those to be active and on treatment, and then we want 95% of them to have suppressed viral loads, indicating that their treatment is going well. And you can see here when they looked at this in 2019, the graph looks a little bit better right now. But we look a lot better, but we're still doing a better job. And part of the reason it's helped is we've introduced a new antiretroviral regimen for adults that's much easier, better tolerated, and more potent. So we're doing a better job, but we still have some gaps in our 95-95-95 cascade. And I need to update this slide. Sorry about that. And we're coming to the end of our presentation, but I think it's a really important message. We've shared some depressing stats and figures and charts from Mozambique, but we know that elimination of mother-to-child transmission of HIV is possible, not just in Europe and the United States and in the Western world, but in sub-Saharan Africa. Botswana, who is one of our regional neighbors, has essentially achieved PMTCT. It's a country with a small population. It has much more wealth than Mozambique does, so it has a much different context. But we have local examples of how we can move towards elimination of mother-to-child transmission. And so Mercia and I are both hopeful that someday we'll have to work on a different disease process, that Mozambique will reach PMTCT, and she and I can focus on malaria or malnutrition or any of the other problems we have here. But this picture rather, and then the link that I put here, I'm not going to show you guys the video today, sorry. But there's a program here called Mothers to Mothers, and Mercia mentioned this before. I'll share the slides later, and you guys, I would encourage you to watch this link because it's a pretty motivational video. But I think this approach that this organization is really unique and doing cool work. So I'd love it if you shared a little bit with them about Mothers to Mothers.
Yeah. Okay.
Yeah, no,
yes. Yeah. Okay. Mothers to Mothers here. It's one implementing partner that has mentor mothers in all her facilities, and those mentor mothers are HIV positive women who succeed, who are virally suppressed, who support other pregnant and breastfeeding women, and also HIV positive children up to 10 years old to achieve to be virally suppressed. We are still lagging. We are adolescent girls, young women, and children are vulnerable population. I can say so. They are not vulnerable at all, but I can say because they are still they are still lagging. They are far to reach 95, 95, 95, and we have the help of the they work in the health facility and also in the community. If you go to an health facility, you find maybe 2, 3, or 4 in the health facility. They stay in the doors and they support the mothers to accept the diagnosis. They escort them to collect blood samples. They escort them to the pharmacy. They go to their house when they miss their appointments. They call to remind them that they have vital load to collect. They explain the importance of U=U, and they help them to disclose their HIV status to their family, sharing their own experience. So all mentor mothers are HIV positive who succeeded. Yeah. So we have this program all along, and now we are encouraging our partners, our implementing partners, to hire young mentor mothers to support adolescent girls who are pregnant to reach success in HIV treatment.
So the idea to be a young woman would have a young mentor.
Yes, we'll have that because we have the adolescent youth-friendly service where the adolescents go to their family planning, and we will have those adolescent girls mentor mothers in these health entry points. But now we have mentor mothers in all main entry points. Antenatal clinic, postnatal clinic.
Cool. So guys, I was less long-winded than I usually am, and we finished 10 minutes early today, so we have good time, ample time for some discussion. So I'm going to stop my screen share and come back to the video screen so that we can see everybody. But I'd really be interested to hear thoughts, questions. I see, Alice and Claudia, Mohammed, some of our Mozambican colleagues are on the call. So if you guys have anything you want to share related to this from your experience here in Mozambique, we'd love to hear from you. Sorry to put you on the spot if you don't want to speak either.
Hi guys, Mohammed here. Right now I don't have anything, but if something comes up, then I'll let you know.
Mohammed, speak a little bit about stigma. Mohammed, guys, is leading a study, helping lead a study that we're doing here, where we're recruiting babies who have HIV who are admitted with severe pneumonia. And we follow these babies, but also in the year afterwards. And so we get to know these families and these moms really, really well. Mohammed, can you think of 1 or 2 patients maybe that you've dealt with through your role in the study that maybe face some of these challenges that Mercia referred to?
Yeah, so recently we had a mother that came in, and she currently lives in her in-laws' house. So for one of the consults that she came in with her mother-in-law. And for some reason or another, we have some psychologists who advise parents and caregivers occasionally on how to take care of a HIV positive child, and if they have any worries and doubts, how to deal with them. And what happened was that this mother hadn't revealed at home that she and her baby were HIV positive. But when she came in with her child and with her mother-in-law, they decided, the psychologist at the hospital wanted to have a talk with the mother-in-law. So she got kind of caught unaware, and she was worried that they would reveal the diagnosis to the mother-in-law. And she kind of got very worried and came to us asking us not to reveal to her mother-in-law because she was afraid of the consequences, and maybe that she would be seen in a different light at home and stuff like that. So we have to kind of juggle the clinical aspects of encouraging the mothers to take good care of the children and keeping them coming back to our consults, with also these social aspects.
It's interesting, Mohammed, one of the things that we know is that the same social factors that contributed to babies getting HIV are going to be the same factors, if not resolved, that contribute to poor treatment outcomes in babies who are HIV positive. And this family that Mohammed referred to, during this child's initial hospitalization, this child was quite sick, was on oxygen, breathing really fast, and the family insisted that this mother take the baby out of the hospital to go to a traditional healer and to do treatment. And we negotiated with her. I pled with her not to do it, but she insisted. But she said, I promise I'll come back the next day. Mohammed and I weren't sure that the baby would make it through the night, but she did come back the next day. But it was not a decision that she was empowered to make for her own child. Her family insisted, and she had to comply. Child off oxygen, leave the hospital against medical advice, and go do this traditional treatment. But we've worked really hard with her and kept engaged, and tried to relate and understand her situation, and hopefully the baby will continue to do well. I see that Alice and Claudia didn't have anything to add. There's a question here from Raven. You want to just read it aloud so that you don't have to listen to my voice anymore, Raven?
Sure. Dr. Matsinhe, you mentioned that there's a lot of trust in physicians in Mozambique. So I was just interested in the role of physician education in addressing these pillars, and if all physicians are aware of programs like Mothers to Mothers.
Yes, they are aware of this program, and they work together in the health facility where mental mothers are present. The provider is the responsible to supervise the activities of the mental mothers and to teach them some health topics for health literacy to the peers. So the mothers also give health literacy to the peers. They explain U equal U to them. They try to see if the medication is being given in the proper way for the children, and they also screen for TB. So the providers were trained last year, for example, when we extended the pediatric follow-up by the mental mothers up to 10, because before they followed up to 5 years old, and we extended last year. And the Ministry of Health revised the training package to provide us, and this training package was designed for the mental mothers, but providers were the one who trained the mental mothers. But they work together. Actually, they work together, and we have other cadres, other community or lay workers in the health facilities who also work together with the providers. We have the orphan and vulnerable children case management, who works with HIV-infected children and orphan and vulnerable children to HIV. This program is designed to help adolescent girls, young women and boys and young men vulnerable to HIV, empower them with health literacy, financial support to prevent HIV infection. And we also have the other program, which is the DREAM. And I said that DREAM is for adolescent women negative. And this program has the aim to prevent HIV infection and has a lot of pillars. And one of the pillars is financial support, health literacy, education in regular schools. They give support to allow that girls go far. They have programs that allow girls to have jobs and they support them to find vocational activities like sewing, cooking, and other things to help the girls to be self-reliant, to avoid premature marriage. They also work with some government departments to prevent or to revert premature marriage. When they find out, they go to the government and try to do everything, because this is punished by law. And in this program, they also do that. So we have a lot of programs, and providers are really involved. But one thing that we are working now is to improve the quality of assistance, I can say so, empowering the providers, because sometimes providers will rely some of the activities in those lay counselors. They will, because we have a lot of a very big demand, and they will leave some activities for them. So now we are trying to make sure that providers do their part very well to improve retention,
and viral load suppression will be one of them. So they have to ask to request viral load in the proper time, explain the importance of those blood collection to parents, and sometimes the payment to do that. But we are trying to empower our providers to feel confident to talk more with patients, because it's something that sometimes it's late in the visits, and we are doing that, and Dr. Chris will be involved. But I know that we will talk to this, we'll say this. Maybe next year we'll have more information about that. Yeah,
Cool.
thank you.
Well, guys, I see your time is running out. I wanted to just make one concluding remark. I think this talk for me is really interesting because I got interested in HIV originally from like a kind of scientific perspective. I thought the medical aspect of it was interesting, but now I've kind of changed course, and really what compels me and why I continue to choose to try to work in this area is I think that the social factors are fascinating, and you can't have the impact you want without being willing to explore these things. And it's a great example of how, as a physician, your work has to go beyond the biomedical interventions, or else your impact is going to be limited. So I'm grateful to have had the chance to share this time with you guys today. And I wanted to just recognize Mercia, and what an amazing thing. When I met Mercia, her confidence in her English was so lacking. She wanted to speak English to me, and now she can go on, and I see a bunch of applause icons there. So thank you, Mercia, very much. And thanks to Vijeta and Zoe and Christy and Tracy and everyone else who helped organize this, and to you as well, Raven.
Thank you all for being here.
Thank you so much, everyone.
All right, you guys have a great day there.
Ciao.